Hello, everybody. Well, it looks like it's 7 o'clock and I think the team's ready to get started. I see Kayla has started the recording, so we'll get going. Just give me one moment here. I just have to pull up a screen. Hello, and thanks for everybody for attending our webinar this evening. Our webinar will be approximately 60 minutes. So let's get started. My name is Wendy Jobs, and I'm the manager of dental hygiene practice for BCDHA. And myself and Mystica Lopez de Leon is also a BCDHA staff person. Her title is policy analyst, and her and I will be moderating the session this evening. I would like to take this opportunity to recognize all of the traditional territories upon which dental hygienists work. If you have any ITs, you can certainly use the chat function or email us at info@bcdha.com. We have the very capable online with us this evening. She's our office manager and IT guru, so she can usually solve most problems that we encounter. We also have a couple of BCDHA staff online to assist Mystica and myself and John with this evening's chat and monitoring your questions and making sure we don't have any too major problems. Thanks to all BCDHA staff helping this evening. I really appreciate it. We are somewhat new to Teams. We've been using it a little bit, but if you want to bear with us if we encounter any hiccups, up here are where your controls are, so you can have a look there.
Sorry, folks, it looks like Wendy's frozen. Mystica, do you want to take on for her?
Yeah, just one second. Let me just share my screen instead.
Wendy, you're freezing on us.
Oh, are we? Okay, go ahead, Mystica.
Okay, yeah, I was just going to take it over from that slide and just describe that those are your options where the purple arrows are, and you can change your view as you need to.
If you run into any challenges putting questions into the chat, you can feel welcome to email those questions to info@bcdha.com, and Kayla will put that repeatedly into the chat window so you can be reminded of where it is. Wendy, you might be back now. I think you look fine.
Okay, thanks. The publication and advertisements for this webinar, which there are none, but we usually like to display our disclaimers so that everybody is clear on that.
Oh, and I believe Wendy's froze.
QAP. Oh, I'm so sorry, gang. Go ahead, Mystica.
That's all right, Wendy. I think you can describe this as just how the CE will be submitted.
Yep, it's called a CE verification form. It's a PDF. It's fillable. The link to this form will be was sent to you earlier in the reminders to this webinar, as well as we'll send it towards the end. You can complete this form.
Yeah,
and upload it to your CDHBC learning platform. Am I freezing again, Mystica?
I think you completed what you needed to say.
Okay, please, we do want to remind you that CDHBC do not send us, BCDHA or CDHBC, a copy of this form. This is for your records only. Towards the end, Kayla will send you an email with a survey. Please complete that. It only takes you 1 or 2 minutes for us. How are we doing, Mystica? Am I okay?
You're okay.
Okay, good. Thank you. We're having some freezing issues here. Our webinar.
Well, Mystica, I think you're just going to have to take over for Wendy.
Okay.
She's coding out us.
Yeah, so our webinar objectives for today are define interprofessional education and collaborative practice and how these should align with the provision of oral health care services. Outline dental hygiene, how dental hygiene should be concerned with interprofessional education and collaborative practice. Describe innovative system transforming solutions that will ensure the appropriate supply, mix, and distribution of the healthcare workforce and how dental hygiene can shape or influence this process. And lastly, describe why interprofessional collaborative practice adds health security to both the community and the healthcare providers. I am going to request control of this. Share my screen instead. Just 1 second. Sorry, just one second. Yep. And Andrea, I think you'd like the honors of introducing John for us.
Oh boy, would I ever. So, hi everyone, I'm Andrea Burton. I'm the Executive Director of the BC Dental Hygienists Association and the CDA Alliance, and I'm so happy to see all of you here tonight. And I'm super excited that I get to introduce John. I'll try to keep it somewhat short, but John is one of the world's foremost experts on interprofessional education and collaborative practice. He happens to be from British Columbia, which we're very grateful for, and he's also someone I'm really honored to call friend. If you've heard the term interprofessional education or collaborative practice bandied about in healthcare, honestly, it's probably because of John. It's really been his vision and leadership that have led to this concept of interprofessional education becoming a central tenet of collaborative person-centered practice. And certainly he's responsible for the movement gaining the ground it has in Canada. I first met John when I was working in government 20 some years ago, and I'd been tasked with figuring out how to get nurses to work better together and with other professions. And I think I was naive at the time to think that I could accomplish that, but it was suggested that I head down to UBC and I meet with Dr. Gilbert, who I was assured could provide all the insight I'd ever need to tackle the thorny problems of how to get professions to work better. And what I discovered was an incredibly intelligent and kind person, and honestly, someone who is immediately interested in you when you start talking to him. He wants to know all the sort of things that make you tick and that you're working towards. And I can honestly say to all of you who've come to know me over the last few years that part of the reason I'm here doing this job today is because of the mentorship and support that's been shown to me over so many years by John. This isn't about me. So to give you a glimpse of John, I'm going to say first and foremost, he holds a title that is probably the one I covet most in the world, and that is that he's a member of the Air Canada Million Mile Club, which means he's flown more than 1,000,000 miles. Very rare that you meet someone who's done that. But it makes sense when you actually get to know him, because along with being the founding principal and professor emeritus of the UBC College of Health Disciplines, John also has worked all over the world, and he's had these amazing roles. So, for example, he's he's a senior scholar with the World Health Organization's Collaborating Center on Health Workforce Planning and Research. He's an adjunct professor at Dalhousie. He has the Dr. Pai Endowment Chair in Interprofessional Education and Practice at the Manipal Academy of Higher Education in India. He's an adjunct professor at the University of Technology in Sydney, Australia. He's been an adjunct professor at the University of Pittsburgh and also at the National University of Malaysia. And he's co-chair of the WHO Study Group on Interprofessional Education and Collaborative Practice. And he's the founding chair of the Canadian Interprofessional Health Collaborative. So you can imagine this is someone who has traveled the world and talked about interprofessional education and collaborative practice at absolutely the highest levels. I'm not going to talk about the number of awards he's earned because it's huge, but I think one that means a lot to him and had meant a lot to a lot of us was that John was appointed a member of the Order of Canada in July 2011, which is a huge honor for someone in the education sector who's teaching and leading and advocating for something so unique as interprofessional education and collaborative practice. So I'm not going to talk anymore. I'm so inspired to have him here tonight, and the wealth of leadership and knowledge and experience he brings is just an amazing thing to listen to and to be able to hear about. So we're very lucky to have him, and I'm really proud to introduce you to my friend and mentor, Dr. John Gilbert.
Thanks for the introductions. I'm just going to quickly ask Andrea to give us a meaningful land acknowledgement if you can.
Fair enough. I would like to acknowledge that the BC Dental Hygienists Association does our business operations on the stolen territories of the Coast Salish people. And for us, that includes the Quikwetlan, the Tsleil-Waututh, the Stolo, the Kaiket, the Chemainus, and the Musqueam. And BCDHA supports social justice and decolonial practices that promote Indigenous visibility. And we will continue to work towards decolonial and Indigenous movements that promote sovereignty and self-determination. We were so pleased to see the decision made by the Government of Canada to start looking at reparations for Indigenous children in the last few weeks. And we know that there's still a lot more work to do. So we are very pleased to acknowledge the stolen territories upon which all dental hygienists and dental assistants live and work.
Thank you for that. John, can you speak to us right now? I can't really see my chat so far or the screen.
I can see
Right
you.
here.
I can
Awesome.
hear
Perfect.
you.
Nice to have you. To start off, could you actually just give us a definition for the topic for tonight, which is interprofessional education and collaborative practice?
Yes, might I first acknowledge that I'm joining you tonight from the historical unceded territory of the Musqueam people, all my relations. So this evening, there are no PowerPoint slides because it would be an awful lot of power and there would be very little point. Because what I would really like to do is to have this conversaciones with Wendy and anybody else who feels that they have something that they would like to know about or contribute. I have to also tell you that I have been familiar with dental hygiene for at least the last 52 years and have been delighted with the attention and care that I've gotten from a number of different dental hygienes because they have retired and gone their way, etc. I think I know a little bit about the profession, but I would not claim to know everything that you know because at the University of British Columbia, you will know there was a bachelor's program attached to the Faculty of Dentistry some years ago. So I'm going to kind of give you the CAPE definition because this is the basis for the discussion this evening. This definition, CAPE, C-A-I-P-E, is the Center for the Advancement of Interprofessional Education in the United Kingdom, which was founded in about 1988 by a family physician, John Horder, who was an amazing person. And he recognized back then that the world was moving towards the practice of medicine. His world was moving towards the practice of medicine where the physician was no longer the chief interlocutor for a patient, that there were other health and social care professionals who played a very important role in the care of because it was his patients. And he put together a group of people who had a similar interest, and they were from nursing, pharmacy, social work, and two other professions, and said, you know, we should have some kind of organization that would bring together the health professions, health and social care professions, so that they would understand that learning together really does contribute to practicing together much more collaboratively. And over the next 10 years, the Center for the Advancement of Interprofessional Education worked on a definition, which is a testable definition. And all of us who are in the front of science are very interested in being able to test our definitions and our theories. And the definition is occasions when members or students of two or more professions, okay? Members or students of two or more professions, because this is not just about students. Learning with, from, and about each other. Very, very, very clear statement. Learning with, from, and about each other to improve collaboration, because that was the impetus for beginning this work. You know, let's see if we can, in fact, collaborate and do it in a much more efficient and effective way than it's been done till now. And at the same time, improve the quality of care, because that would be the aim of learning with, from, and about each other. Improve the quality of care and of services. Because what became very apparent was that you don't get improvements in the quality of care if at the same time you're not trying to improve the services which are responsible for providing the quality of care. Now, let me flip back to 1964, when the Dean of Medicine at the University of British Columbia, Jack McCreary, wrote in an article in the Canadian Medical Association Journal words to the effect that the ideal education at the undergraduate level for all health and social care professionals was to learn together in the same classroom, in the same clinic, on the same patients. I mean, that was a huge ideal back then, and there was a program or a committee at UBC which attempted to move that forward, but without much luck, and for very, very obvious reasons now, we understand that. Now, let me come back to the definition. Members of or students of two or more professions with, from, and about, improving collaboration, quality of care and services. I want you to understand that that is a continuum. You know, it is you start and then you move through each of those things, because at the end of the day, you really want to see that what you've done in education with respect to learning with, from, and about each other, what you've done with respect to understanding what collaboration and collaborative practice should really be, really does lead to an improvement in the quality of care and services, which is noticeable and measurable. Now, one more thing that I would like, one more thing I have to say is that why would this come about and be so important? Well, again, we flip back to the 70s when the airline industry was absolutely shattered by two awful accidents, okay, when people lost their lives. And the airline industry said, gee, we better do something about this, you know? And what they discovered a couple of things. One, which was very obvious after the fact, was that the pilot, as he was called in those days, considered himself, because it was hims in those days, no hers at that time, to be the chief of the organization. So when the plane gets in the air, the pilot said, I'm in charge. So it wouldn't matter if the flight attendant at the back of the bus says, hey, the engine's dropped off. If the pilot didn't agree, he'd say, well, that's too bad. And the airline industry began to look very seriously at safety issues, right? Said, why did that happen? They discovered some things that we know about in dentistry. And that is, and in dental hygiene, that is, the guys were bending over to find the appropriate knob when they ran into the mountain. It was in the wrong place, okay? And secondly, they weren't talking to each other. They were each doing a job in separate places, right? And that's a catastrophe. And thirdly, the design of that front end of the airplane, the flight deck, used to be called the cockpit, but it's called the flight deck. All of the devices were in the wrong places to fly efficiently and effectively. Now you think about your clinics today, and you think about how well organized they are. You know, the development, a friend of mine in dentistry said to me, do you know, John, the true largest development in dentistry after the discovery of fluoride was the chair. Because I remember when I was a child going to see a dentist and I was sat in this huge iron chair. And I didn't think about that, but those poor dentists and their assistants, you know, bending over and reaching and so on, it must have been awful. So learning with, from, and about each other to improve collaboration, etc., reflects back to safety and quality, right? And it's my privilege to be a member of the BC Patient Safety and Quality Council. So, Mystica, that's the start. That's the kind of basis for where we go to look at each of those individual parts and say, what do we do about the first part? What do we do about the second part? What do we do about the third part?
And without that communication, you know, how do we get anything done in any organization at all? And I guess like your analogy of like, let's say the plane, that plane, we can look at that as the one patient, and we're all a part of that patient or client's well-being. And if we're not working together and with the patient, then we're just hobbling around. So I guess that kind of leads to my second question. When we're thinking about safety and quality and how the healthcare system right now kind of mostly is, like, let's say for our everyday dental hygiene practice, which is usually situated in a dental practice for a majority of the clinical positions, what does that mean when you know, people are working on their own tasks?
Yeah, that's a problematic question.
And it applies to not just dentistry.
No, that's correct. And it actually applies, had applied to a lot of the health and social care professions, kind of working alone and not recognizing that there were other people that they should be in contact with. My view is that it's, I think, incredibly hard for dentistry and dental hygiene because the practice that you are engaged in is not in, except unless you're working in public health area. If you're a dental hygienist working in public health area, which is different, we can talk about that. But there's no real contact with other health and social care professionals, right? And it's for economic reasons, it's for professional reasons, whatever. And that presents a lot of difficulties with respect to learning with, from, and about each other. So let me give you an example of what happens to me, because I'm sure you all do it. It's part of your everyday practice. When I go in to the dental hygienist's office, the first thing she asks me, and I'll bet you know what it is, have you been having any problems with your teeth? Okay, first question. Now, if I say no, she says, okay, and then she asks me, do you have any medications that you're on at the present time? But one of the things that we've recognized about the health and social care systems is that at base, people are in this whole arena of social determinants, right? They're in a place where they come from, where they work, who their loved ones are, etc., are their life. And it seemed to me that if I have said, it seems to me that if the dental hygienist that attends to me had said, oh, so you haven't had any problems, but tell me, what did you do today? Just to take you forward to understanding where that person come from. So in this day and age, we are actually trying to train our medical students to ask that question before they ask anything about the health of the patient. Okay? The question is, okay, so tell me about today. You know, what did you do? How's your family, etc., to get a real understanding of what it is the patient is, okay? Now, William Osler, my great hero in medicine, said, it's much more important to know what sort of a patient has a disease than what sort of disease a patient has. Isn't that interesting? What sort of patient? So one of the reasons for asking that question at the beginning of your interaction, and I know that I'll get to that in a moment, is because it then gives you an idea, if you discover something in the mouth, about where this person comes from, what it is they do, etc. Because you're going to be the dentist might be asking a question about, you know, does this person have access to, etc., etc., etc. So it's really important to get that little piece of information. Now, I recognize, as I said, I was going to say a minute ago, that of course you are bound by input or throughput, right? You've got to get that patient through the practice because that's the income of the practice. So you can't spend much time on it. But I would suggest that in the education of a dental hygienist, it would be possible to build kind of a couple of little questions that the dental hygienist could ask of the patient that don't interfere with the practice of dentistry. I understand that thing, but gives the dental hygienist a good idea, all right? And then the second question that's asked about, are you on medication, is not just to take down the medication that's the patient is on, but to ask why, how long, how often do you take your medicine? Because compliance is one of the biggest issues, right? We know that, you know. The number of people who are given an antibiotic and take 4 and feel better and don't take the rest of the series. I mean, it's so common. So getting that little bit of information is really interesting, because then it gives you a sense. Now, over the years, of course, if if you're like me and the dental hygienist is in place for a long time, we get to know each other and she gets to know me, and we talk about my grandchildren and et cetera, et cetera. But she still asks me, because I told her to ask me about what I was doing today. So some little things, a little tweaking, some little polishing, some little whatever at the beginning of the learning of being a dental hygienist kind of takes you a little way towards this learning with, from, and about each other.
And that includes the patient.
And that includes, so that's why.
Or client, sorry, client.
Yeah. Well, I don't mind. I mean, I don't get fussed.
Whichever anybody subscribes to.
But I mean, it is important to recognize that, see, people do get uncomfortable if you say patient instead of client. That's okay. But yeah, the notion that that person is now part of the team of work. So what we're trying to do is to talk about patient partners, right? Our patient is our partner. And the Patient Voices Network in British Columbia is incredible about this. They're teaching now, et cetera, et cetera. So regarding the patient then as part of the team, not as somebody you're just working on because they've come into the office. They're now part of your care. And getting to be part of your care is you getting to understand where they're coming from.
I'll get back to the Patient Voices Network if we have some time. But let's say, because you gave us a good amount of history on how it started in Canada. So let's say, like, the research surrounding interprofessional education and collaborative practice has been ongoing for decades. But from what I've seen, most of the application is either in public health or in education. Are there some, let's say, programs or health systems that are really leading the example right now?
Yes, there are. Let me just come back to your literature point. The literature has been really, the research that's is being done on the first part of that definition, learning with, from, and about. And what we know is that if you put students from 2 or more health social care professions together around a health problem or a social care problem, they just love it. They love that kind of learning. And the learning just, it's logarithmic. I mean, it's just amazing how it works. Now, in Canada, at the University of Montreal, they have an amazing program working with the patient partner. And they actually have a whole guidebook for how to do it. It's a great program. McGill University has a fantastic community-based program. Western University in Ontario has a program that goes back a long time, as does the University of Alberta. Now, the programs are all somewhat different, but at the base of those programs is this definition. You got to learn together in order to practice effectively together. In the United Kingdom, there are some really, really good examples of this. The United States is kind of bound ahead of Canada. They used to be way behind us, and now they have a huge center at the University of Minnesota, a research center. And there are a number of that down the road at the University of Seattle in Washington. It's a very, very good program. It's been around for about 15 years now, 20 years. So yeah, there are programs. The difficulty, though, Mystica, is that if you want to look at these kinds of interactions, because they're all it's a mixed method, right, approach to research. And we have a lot of people who are either, if I can't test the null hypothesis, it doesn't exist, or at the other end, which is, oh, I just want to hear stories. Now, what
stories about how we work together.
Yeah, how
right now I feel good.
Yeah. Now, Andrea Burton told me that if you go to the Minister of Health, the minister loves stories, because when she goes out on the canvas, she can tell stories. But if you talk to the senior civil servants, they say, I like those stories, but where's the data?
So that they can back whatever the next decision is up, and it depends who you're talking to.
That's right. So what we've tried to do is to build this mixed method approach to interprofessional education for person-centered collaborative practice, so that first of all, we can collect data, and then we can ask stories about the data, so that when we go to a skeptical deputy minister, we can say to her or him, hey, Andrea at some time might tell you a wonderful story about one of our deputy ministers. You can say to him or her, look, here's this data on how much better the care was when we did. So the Patient Safety and Quality Council, for instance, did an amazing amount of work on sepsis. We all know the problem with sepsis, right? And what we've done in British Columbia, by working collaboratively, they didn't know they were working interprofessionally collaboratively. What happened is that the sepsis rate has come down and down and down. We have the lowest sepsis rate in the country. And it's because of this kind of understanding that you got to learn about the other person in order to fix the piece that you don't understand. Okay, so there are places, and the data is getting better and better, but it's a young field, and it takes a long time to kind of get into the literature so that people say, oh, I should read that. So I have a little rule that I tell people: read an article every day.
In particular, are you aware of, in the periphery somewhere in the world, that they've really incorporated, let's say, dental or dental hygiene more into the broader system and are actually working collaboratively with them?
No. And I think I saw something come up in the chat about payment and so on. So we'll probably have to have a little. No, because unless you have, and if you go to the developing world, or you don't find a lot of kind of health and social care professions you find here, right? I go to India. I don't think I see many dental hygienists in India, right? Now that's maybe because I haven't looked, but it's not. In the developing world or in low-income countries, it's having community health workers, which is absolutely vital. And some of those community health workers are picking up notions that, if it's in the mouth, it could be in the gut. If it's in the gut, it's bad for health, right? But that needs a lot more development. I've been talking I've been talking to my colleagues in the university I'm associated with in India about this issue, that we should be talking about, how with the community health workers, we can give them some education around dental care, okay? And because there aren't that, the dentists are fewer than doctors in India, as far as I can see.
Now, this is kind of rounding back still to the same can of worms that we've opened, but actually this is more Wendy's question. Wendy, if you can speak, did you want to ask about the tribalism of professions, or should I?
Hi, Mystica. Can you guys hear me okay?
Yep,
Yes.
fine.
Thanks for that. I'm going to keep my video off because I think that's part of the issue. Yeah, no, thanks, John, for that. That's great.
Sorry, Wendy. I guess I'll ask this one for you.
Problems in.
So Wendy's question.
Okay. Thanks, Mystica. Sorry, guys.
No, it's okay. Interprofessional education and collaboration are viewed as antidotes to the persistent problems of oral healthcare delivery, like what we call the tribalism of professions, and the tendency of various professions to act in isolation from, or even like in competition with each other. It's been identified as one of the reasons why change hasn't happened. Can you kind of tell us how to overcome this tribalism, or what it even is for somebody who's just tuning into the issue?
Yeah, that's a very, we could spend another 4 hours talking about this. So we talk about the silos of education and the silos of practice. And again, I'm going to do a little historical flip, because if you go back to the beginning of the 20th century, there were essentially only 4 professions that dealt with health and social care: medicine, pharmacy, social work, only it wasn't called that in those days. It was called something different, and the emergence of nursing, right? Nursing had been around, for a couple of thousand years, but it was mostly midwifery. Anyway, so at the beginning of the 20th century, you have these kind of 4 professions, medicine being the dominant one. Medicine told everybody what to do. And in about 1912, 1914, educationists in the United States wrote a report about this problem and said, listen, if we really want to change the practice of medicine, we better put medicine in the universities. We better make sure the research is done in the universities. We better make sure that all those fake barbers who are out there with poles outside saying that they're doctors are struck off the list. Okay. And so there began to emerge in the United States this notion that everything to do with medicine should be done in concert with the university. Now, as the century progressed, parts of the body and disease entities began to be taken over by other people than medicine. Okay, so I'm very familiar with physiotherapy and occupational therapy because I was director of that school at one time. And so physio and OT began to emerge. And as these professions emerged, dentistry to be included in there, they wanted to be like medicine. So what happens? They began to imitate the structure of medicine within the university, well, outside of the universities, and then within the university. Outside of the universities through regulation and accreditation, for example, or regulation and legislation. And so over the period of the 20th century, you get this kind of thickening of walls around the silos, right? So, these professions are building, the biggest and best of whatever it is that their profession is supposed to be about, and not even understanding that outside of the wall, there's some other profession. So when I started, in the field at UBC, and I'm not that kind of professional, it struck me as rather strange that people really didn't talk to each other. Well, why didn't they? Because
they had to establish themselves.
Well, yeah, and they had to establish, and there was a building for medicine, there was a building for pharmacy, there was a building for nursing, did they ever join with each other? No. And Andrea Burton will show you a cartoon which we made up to illustrate that fact. Okay, so it's been incredibly difficult to get people outside of the walls of the silo. I used to say, it always reminds me of an Italian kind of hilltop town, we'll let the visitors in for the day, but at the end of the day, you all got to leave. So, we'll welcome them and talk to them. So it's a very, very, very difficult problem, and legislation and regulation have not done a lot to help it, because they've made those walls even thicker. Just think about, how hard we work to make sure that our program in dental hygiene is accredited, and then all the things you put in around scopes of practice. So what we find is, there's scopes of practice which really do overlap like this, but the people where they overlap, they don't know that they're overlapping. So that's my job. Oh no, that's my job. Oh no, I should do that job. You say, wait a minute. The patient should be the focus of our attention. I once gave a talk, the patient's not a hockey puck, right? Mm-hmm. So some people talk about teams and they drive me nuts because what they do is they show you a photograph of a rugby team or a football team. And you look and you say, so what's that? Is that the patient you're throwing around? Ha! And so we kind of lose sight of the fact, as good old William Osler wanted us to know, you got to keep that person as the focus of your attention. So then if you have a patient coming into your practice, oh yes, there it is. Thank you, Andrea. If you have a patient coming into your practice and you see something akin with the face, maybe bite marks. So our great suite at UBC was, I think, the first forensic dentist to say, that looks like abuse, right? So then you begin to say, well, our role is a bit bigger. I have to go talk to the dentist about it. Or when the dentist comes in, you say, because in my case, it's he comes in and he says, how are you doing? Looks at my teeth, He says, oh, gosh, you got a bit of dental archaeology here. My dad put that in 40 years ago, looking at some. But the issue then is to have that conversation of something you've noticed or something that the client has told you that
They're concerned about, yeah.
That is going to be a concern, yeah. So I'm not sure, because I haven't looked at this, I'm not sure how the relationship works between the dental hygienist and the dentist. Okay, so you'll have to forgive me. I know some of the things, but I'm not entirely clear about how that relationship works and where if there is a boundary, where the boundary is between what you as a dental hygienist can do as opposed to what it is the dentist is doing. Because there's a wall there, I'm sure. It's a silo, right?
There's a wall there, and it really depends per practice, and every clinician themselves, they come from a different institution, they trained 20 years ago, 2 years ago, and they have different experiences that they bring. And I can't speak for every practice, but there are some boundaries professionally.
Yeah, well,
around.
I think that's a good, that issue of age is, of course, across the entire spectrum of health and social care. We have the youngest, and then we have the oldest. Now, I always say you have to be really, really aware of not practicing for 20 years what you practiced in your first year, right? And there are people, unfortunately, who still, after 20 years of doing what they do, are still doing the same thing. And if that's the case, it's almost impossible to learn from somebody else about what it is you might do differently, because they're, part of that activity. So that is a very, very big issue. The issue of, is that your job or my job? Well, no, actually, it's about the patient. What can we do that's the best for the patient?
Now, let's say context is key. How does our current system in BC kind of enable or disable professionals that want to practice more collaboratively, or maybe learn a little bit more about what interprofessional collaboration is? Do you see, like, let's say I'm going to bring up amalgamation, but do you see colleges amalgamating together, like from various professions? Let's say oral health is amalgamating into one college eventually. Do you see that as a step to improving the system?
Well, I'm not sure that I can answer this absolutely articulately. Oscar Wilde was the last person to talk in perfect sentences, and I'm not Oscar Wilde.
Neither am I.
But Andrea would tell you that, 20, 25 years ago, I was really, really focused on the educational institution. It seemed to me that somehow or another, we had to change the educational institution. And what I discovered is that it's very, very, very difficult to change educational institutions within that institution. Okay, UBC is incredibly difficult to change. The place where change has taken place is practice, of course. If you just look at your own profession and you say, think of the technology which has come into dental hygiene just in the last 10 years. It's really quite phenomenal, right? And then think about how you would want to amalgamate that kind of learning with other kinds of learning. Well, you have to start with the patient. Okay, if I had my druthers, I'd get rid of all accreditation, everything, and start over and say, here's a patient with a problem. What's the problem? And how do we look at that problem so that we can help the patient to get better, right? So amalgamation. So there have been attempts, for example, to have faculties of health sciences at universities, and there are lots of them around. Well, you say, well, what do you do that's any different than if you were just, off in separate departments? Not a lot. It's only now that I'm beginning to see in faculties of health science in the United States, for example, there is a move to try and make sure that the curricula of each of those programs overlaps and intertwines, so that if you're going to talk about taking a case history, for example, you have to understand how other health and social care professionals are taking a case history. Because, when you get into a team, does everybody have to take a case history? Well, if you look at scopes of practice, you're supposed to take a case history, et cetera, et cetera. No, that's a waste of time. All right. But getting to that place is so difficult. So it's my privilege to have an appointment at Dalhousie University. And I've been very impressed with some work they've been doing in their family practice, where unfortunately they don't have a dental hygienist, but they have a physician, a pharmacist, a nurse practitioner. They have a psychologist, a physiotherapist, and one other person, maybe one other person. And it's interesting because at the beginning of the day, they get together and they talk about the schedule of patients for the day. Now, do you or does the dentist and the dental hygienist talk together at the beginning of the day for half an hour over a cup of coffee or whatever with the admissions person, where they focus entirely on who's coming through today? Or the dental
I've only been in a couple offices that do that religiously.
Well, we need the religion. Let's get religion, right? Because at the end of the day, what they do is, so they kind of figure out, does Mr. X need to see, does Mrs. X need to see, does baby whatever need to see? And they figure who it is that would be best suited to see that patient. And they leave slots in the schedule for the day so that if there is an issue that really, this person should see the physician, then this person's able to see the physician. At the end of the day, they come back in and they talk about, the patients. Okay, what did we find out today? Now, it seems to me you could do that in a dental practice really easily, and it would begin to really develop this notion. Well, I am learning, now I know dentistry and dental hygiene are pretty close together, but I am learning some things that I wouldn't otherwise learn because I'm down the hall and he's up there. He's doing his bit and his assistant is doing her bit. So I think that kind of I don't want to say consultation, discussion, the chat about the load that's coming through that day. And you may not need to say very much at all, you could just say, well, no, she's not a problem, blah, blah. But if there is a problem, then you can spend a little time talking about that person. And I think that's a hugely important way of learning. And then you can say, oh my God, I really think Mrs. X needs to see a social worker. How do we go about that? Because she's told me in this little conversation we have at the beginning of the, etc. Go ahead. Sorry.
Oh, no, it's okay. It was going to bring me to kind of another point, because right now it seems like referrals are, there's some challenges in it. It's either, the referral has to come from this particular type of doctor, or you don't know how to get them to a social worker or something like that. And you have to spend that time. And by the time the patient's already gone and you've learned how to do it, they're gone for the next 6 months. But, there's this focus on referrals, but how does the connection between the professionals and the patients all together continue? It's just one component of working together. But like we were talking about, the patient's not a hockey puck or a soccer ball. But with our environment, it just feels like that's the most we can do at the moment.
Yeah, there has to be a lot more work in the educational programs then about the need to do that kind of thing, and understanding. And I don't know, because I don't know the curricula of the dental hygienist or dentistry for that matter. I essentially know what the dentistry students do, but I'm not completely familiar. But if the curriculum is focused entirely on the mouth, right, then you miss out those social determinants. If you don't have things in the curriculum that talk about social determinants of health, that talk about referral practice, you'll never have this kind of collaboration. And I don't say that it's easy, and I don't even declare that it's possible the way things are at the present time. But you know what Audrey Hepburn said? The word is not impossible. The word is I'm possible. So we have to keep thinking.
I was just gonna say, I guess because we have all these challenges, it means we actually have a lot of opportunity.
Yeah, right. Yes, we do. But it means, you know, sitting down and taking a look at that, taking a look at the curriculum, you know, the educational curriculum, but also the way in which the practice is organized. Why is the practice always been that way? You know, why does it look that way? Why haven't there been changes? Why, et cetera, et cetera, et cetera. And yeah, I'm watching Creatures Great and Small, as I'm sure a lot of you are. And, you know, here's this young veterinarian coming into the practice saying, you know, we really need to change a few things. And the old veterinarian say, well, what do we need to change? You know, reminds me of another story, but you know, today is the day to start. You know, you plant a tree today because you want it to grow into a beautiful tree in 10 years' time. So, you know, you have to somehow or another get together to think about other things outside of the mouth that inform your practice and allow you to begin to think, oh, you know, so how do I refer? Now, I agree, referral is a terrible issue. I mean, it's bad enough in medicine, right? So yes, how do you, so again, the issue is, let's try to figure it out. Let's try to work out how we're going to do this. Who are we going to talk to? Who are the regulatory bodies that need to understand this? You know, blah. It's really, really, really important to begin kind of thinking about how to do that. And Andrea's heard me a lot about this kind of thing. You know, changes. There's a story about a prime minister of England. You know, at the end of the 19th century, and his assistant comes to him and says, you know, Mr. Prime Minister, I really think we've got to have some changes. The prime minister goes, change? Who wants change? Don't we have enough trouble as it is? And you hear that a lot. I mean, that's really, I mean, I find it funny. But you know, you approach somebody and you say, how about we kind of take a look at tweaking? And they say, well, wait a minute, we've always done it this way. It'll take a lot. I don't know that I want to go through
it. We don't have time. We don't have time. Manpower.
The biggest excuse is time, you know.
And cost, I guess, or.
Well, Andrea's heard me say that, you know, you've got to think about what your budget is, and then you are not going to get anything more. You have to say, how are we going to change our budget? How are we going to reallocate pieces of the budget to do things that we really know we've got to do because that's where we're going. That's where we've got to be. Yep.
That's where the future is. Now, speaking of future or present, I know we're coming up to the hour in a bit, so I wanted to save some time for this. And it might be a very, very simple answer, but how has the COVID-19 pandemic influenced interprofessional education and collaborative practice?
That's a very interesting and thoughtful question. Task sharing has become huge, and task moving has become huge, right? As the system has become fatigued, it's become obvious that things that, you know, traditionally X, Y, and Z professions thought only they could do, they realize somebody else has got to do it. So you task share and you task shift. We've seen a lot of that, and there are some papers now coming out about what that has meant. So, for example, in Quebec, because they didn't have enough nurses to go into the long-term care facilities, they had occupational therapists working there as long-term care aides because they didn't have anybody else to put in. So then you say, oh, I've got to learn how to use my skills in a different way. Because you know, we all have brilliant educations, you know, but we just have to learn how we're going to use it in a different way. But yeah, it's been very interesting. We just wrote a paper about this. It was published like last month, looking at just that kind of issue. Very now. I don't know how it's impacted dental hygiene or dentistry. All I know is, of course, that everything was closed down for like 6 months. And then there are certain things you can't do. I mean, a dental hygienist can't do in the office at the present time. But it's really impressive, again, how, because I have a really wonderful dental hygienist. She just is fantastic. But just to watch how she adjusted her practice to the constraints that have been put on her by not being able to do things because of COVID. So yeah, it's a very, very interesting issue. And you know, I can see lots of things. Give me another 3 months and we could talk our way through lots and lots of different ideas.
Interesting for you to know, actually, something that's come out in BC. Now, I don't know about other provinces, but actually, our ED worked very hard to get dental hygienists to help out in the pandemic in a different way, let's say by doing the nasopharyngeal swabbing or vaccinations. And Wendy brought that up in the chat too. And it's a temporary change of scope, but you know, we'll see where it takes us into the future.
Yeah, and does it need to be temporary? You know?
That's something that we've asked also.
Yeah. Oh, I'm sure that Andrea's asked that question too. Yeah.
So let's say we wake up tomorrow and everything has changed in a perfect healthcare system way where let's say things are perfect. Who does it benefit for healthcare professionals to really work together and with the patients?
Well, I think the benefits, accrue definitely to the patients, but the benefits accrue to the professionals themselves. There's a growth that takes place, an intellectual growth that takes place, a mental growth that takes place, a personality growth that takes place. When you begin to see kind of fullness of what this offers, as opposed to the rather narrow view that you get when you're trained as a professional. I have a wonderful colleague at Dalhousie. She's in nursing, and she's been working on professional identity, which is, again, a huge issue. I mean, the kinds of questions you're asking me are related to professional identity. But she said, John, I read a lot of university catalogs, and particularly university catalogs around health professions. So she goes and looks at, what does nursing say they're going to offer? What does dental hygiene say they're going to offer? What does medicine say they're going to offer? Blah, blah, blah. She said, if you look at them, none of them say, oh, and at the end of the day, you're going to work in a team. None of them say that. None of them say, oh, and we're actually going to train you to be a collaborative team member. It's fascinating. So if it's not there, and a student entering the program isn't told right from the get-go, you are a member of a team when you get out of here. So we're going to train you to be a member of a team while you're here. That's where we got to get. Yeah, give me a few more years and I don't think we'll see the perfect world, frankly, Mystica, but we can try for perfection, but what the heck?
I remember something that you told me, or something that you asked me when we first met, was if we were going to solve all the world's problems in one session.
Yes, right. We're not.
We're chipping away at it a little bit.
Yeah. I mean, I like to say I'm the president of a worldwide organization called Hopeaholics Anonymous.
It's good to have hope and keep
it. Good to have hope, yes. I mean, and otherwise, I think you just go on grinding through every professional day. Now, I think that there are, of course, people with whom you can't work. It's undoubtedly the case. My professional, personal, and then personal observation is there are some people who enter professions and can't get out because they've committed themselves and they really hate doing what they're doing. And it's very difficult to work with those people. I'm sorry, but that's a fact of life. They are there. And so, getting around those professionals is very difficult. But thank goodness, there are not a lot of them. But I do think that when we bring people in to be trained in whatever health social care profession, we said right from the get-go, you are going to be a member of a team, and we're going to train you to be a member of a team.
We condition and haze them.
Yeah, right, exactly. I mean, yeah, that's otherwise they'll go out, and then the industry itself will be expected to train them as team members, and the industry isn't so great at that. They do. The industry just wants to get throughput. Again, let's get them out of here, instead of saying, well, what's best for the patient?
Now, so we are at 8:01, and I'm wondering, does anybody have any questions from the chat that you think we should bring forward now? Or we can always bring some of these questions to John, and he can answer them maybe separately. But I know our hope is that we can bring you back again, and we'll present in a different capacity, and hopefully with a different profession or more professions also. That's just our hope for now, not putting you on the spot. And yeah, anything in the chat that was really relevant?
Well, there's some interesting, Lizanne Monroe, thank you. Yes, we've got to stop dividing the industry into doctors and servants, but again, that's a difficult one. I have hope about that. I do. Because when I look at medical undergraduate students now, there is a different mindset about the profession. And the way in which those young people see their lives once they graduate. It is different, but you're right. I mean, the mindset is there, and it's there because, again, we still have not told those people you're going to be a team member. I remember talking to a surgeon friend of mine. I said, well, don't you work in a team? He says, yeah, I know my team. It's the nurse Watson down the hall. So I don't want a dentist to say, yeah, I know my team. It's my hygienist down the hall. That's a terrible mindset, and we can change it. You can change it. There are lots of interesting questions.
Yeah, I just wanted to know, John, if you could tease out a little bit for us. Oral health is really separate in terms of healthcare in this province. So it's not held in the same part of the ministry, doesn't attend the same meetings, although we're battling into those roles. And even in the Ministry of Health's primary care plan, there is not an inclusion of oral health. It's separate. So they're building all these collaborative practices, but we're not part of it. So how do we start to change that to get the rest of the healthcare system to recognize that the prevention of oral health problems, which is really what a dental hygienist's primary focus is, that some of that early warning, that prevention would actually be a game changer for everybody and really get integrated into that primary care system in a meaningful way.
Yeah, I mean, you and I have thought about this in kind of different ways, Andrea, over the years. And again, I'm just going to tell you a story about a friend of mine who was a senior academic in dentistry who said, John, we know exactly how many dentists we need, and we train exactly how many dentists we need. Now that tells you the whole story. If dentistry can't change, I don't know how we're going to change oral health care. Honestly, I don't, because there has to be a move towards this understanding of being part of the team that takes care of a patient. And when I walk out of the dental practice I'm in, I still have, I'm still a patient in a system. I'm not just that, and that has to be right. Dentistry. I mean, why did we carve off the head and say it's not part of the body? We'll give it to these guys and they'll call themselves dentists. It doesn't make any sense. But until we can change that kind of mindset, I'm not sure we're going to move very much forward yet. Unless it was possible for the system itself to say, hey, we need now to really build dental hygiene practice in the system where the dental hygiene, a bit like nurse practitioner. Remember the whole fight we had about nurse practitioners and getting them in, and all of the family docs saying, oh, you know, blah, 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 blah. Well, guess what? You know, we have pretty good nurse practitioner practices now. So kind of beginning to think about, you know, how do we get the system to recognize that if there's a problem here, there's a problem down here. If there's a problem down here, you can be damn sure it's going to be a problem forever and ever. So let's get this cleared up. And I don't think that our ministry quite understands that either, right? Because we've got to keep telling that story. The mouth is the portal to all kinds of terrible things happening. And I don't want them to happen to me, which is why I have such a wonderful dental hygienist.
And I'm glad you really recognize that. And Andrea, you too, you could have stayed in nursing forever, but you came over to us.
Dental hygienists are much kinder people.
She saw the light. Yeah.
Well, I think you see the need, right? And I mean, nursing has had thousands of years of advantage. A little bit less for dental hygiene. It's much newer profession. There are advantages and disadvantages. The advantages, we have an opportunity to have change happen a lot faster than nursing does because they are so inured in it, right?
Well, thank you, Kim Lang. Very interesting observation. Yes, dental hygienists have never, set up practice in an integrated health clinic. Why not? Well, there's a fee payment problem issue. Nurse practitioners have the same issue. But thanks for popping that up there. It's a very important point. Yep. Okay.
It's one we're working on right now, but there are some barriers that usually come back to how dental hygienists are paid.
Yeah. Well, but it was the same for nurse practitioners. I mean, it's not a unique problem, right? And what we don't want to get is to a fee for service model. That would be a killer. Then everybody be treading, patients through, and that would defeat the purpose of collaborative practice, in my view. That's the problem we have with primary health care, right, at the moment. It's because we have kind of fee for service. We might see that change in my lifetime, but who knows?
But we are in oral health fee for service in every way, right? Which is part of the challenge, because in talking to the ministry and saying, well, when you did nurse practitioners, there was money given for those startups. There was money given, and we have a couple hundred independent dental hygiene practitioners in this province who can and do set up their own businesses and work independently, but they certainly don't have the supports that nurse practitioners have gotten from the system. And that's partly the recognition of the need is different. So doctors are the first to say we can't do everything. Dentists don't say that.
Well, what did I say? You got to get back to those dentists. And the thing is that nurse practitioners had a bullhorn. They had nursing, and that's a big bullhorn.
Yeah.
Dental hygienists don't have a bullhorn like that, right? So it is up to the dentists to keep making that point. They've got to be out there. They've got to be an integrated practice, and it's crazy that it's not. And I'm going to leave you with this story, because I had a mother come to me to talk about her, and it's okay because this is all now in the public domain. Talk about her autistic child. Her child was 22 or 23. And as you know, when you reach the age of 18 or 19, I can't remember which one it is, Andrea, you move out of the care system almost entirely. So this young person was having terrible dental problems, just terrible. And he was clearly in agony. And she went after the minister to get care. But she was, I think, successful partly in the end, but you shouldn't have to hammer like that for fundamental care. It doesn't make sense to me.
It's demoralizing.
Very demoralizing, yeah. And if you're a parent, it's really sad, yeah.
Yeah.
This has been great. Thanks for inviting me.
I think you might be back. We've already had requests for bringing you back, so.
Okay. Well, that'll be my pleasure. It's always wonderful to talk with you, and these are big problems. But as I say, I'm possible, not impossible.
Now, Andrea, I was just going to ask, would you have anything closing to say?
Well, other than saying, an enormous thank you to John. And I think from what I'm seeing in the chat and some of the staff comments, I think people are realizing what I've known for quite a while, which is that listening to this man is not only a pleasure, but you learn something every time. And I still learn something every time I talk to him. So we will have you back. And we've talked a little bit about ways that we can work with John a little bit more. Because for me, if you haven't heard me give the spiel, one of my priorities is to really look at how we get further integrated into primary care, because leaving out and omitting dental hygienists in the primary care system in this
That's crazy.
province is terrible. It's terrible.
It's crazy. Yeah.
So we're working on that, and I've said to a couple people, if you want to be involved in some of this, please email us and let us know. Mystica does have an interprofessional policy table that will continue to be working with John. But yeah, this was great, John, and we will certainly be inviting you back.
My pleasure. It's good to see you. And thank you everybody online for coming online. I know you all have very, very busy days, and come online at 7 o'clock at night and hang in here till 8 o'clock. That's fantastic. Thank you all so much for being here. And thank you both for your support. I really appreciate it.
Yeah, thank you for supporting us, John. And I'm really happy to hear you are in Canada as well as I am in Canada too. For everybody else, we will be giving you guys a survey. We'd love it if you guys can give us your feedback. And if there's any big questions that we screen in the chat, then we'll bring that to John, and we might answer some questions and forward it to you guys afterwards. But yeah, this isn't the last time. We haven't fixed everything yet. And, you know, it's a, how do I usually, I say it's a dental hygiene practice. It's not a dental hygiene perfect.
That's good. I like it. All right. Well, thank you.
Thank you, everyone.
Stay safe.
Thank you.
I'll see you. Yep. Bye now.